Welcome back to Medication Management in Patients with Advanced Illnesses. This is Module 2, Pain Assessment and Management, Part 2. This is Dr. Diana Stewart, and with me I have Drs. Mary Lynn McPherson and Nikki Brandt. For this objective, you should be able to list the components of the PQRS-TU symptom analysis. That's a bit of a mouthful. You should be able to list 3 validated tools for pain assessment, describe 3 classifications of medication for pain management. So starting out with pain assessment, this is really an essential component of doing optimal pain management. If we don't know what we're treating, how could we possibly treat it right? But who should be assessing for pain? I think that anyone involved in providing care to the patient should assess patients for pain. Dr. Brandt, what do you think about having people who aren't the physician assessing for pain?
I think this is critical. Oftentimes, especially in the post-acute long-term care segment, some of the best pain assessments I get from some of the aides that come in, and we see the patient when they're giving them a bath. So I think it's imperative that we look at all kinds of times, because as oftentimes the prescriber, whether that's a physician or other nurse practitioner or physician assistant, they're only seeing them for a very short period of time. And pain, again, needs to be gathered, and you're going to get into the assessment in a systematic way.
Absolutely. So what is your role? Like Dr. Brandt said, all team members can facilitate pain management. And some of the ways that you can do this are simply by observing the patient. Do they look like they're uncomfortable? Are they grimacing or pulling at the sheets or gripping at the bed rails? Ask your patients if they have pain and if that pain is managed. Ask patients how they take their medications. And also report any evidence of uncontrolled symptoms or medication non-adherence to the nurse or provider. When should we be performing these assessments? Well, at the very least, we should be doing these at regularly scheduled intervals, so we aren't just doing them willy-nilly. Absolutely, you want to complete a pain assessment before or after initiating or discontinuing a medication, because these could lead to changes in the patient's level of pain. Anytime you change a medication dose, so if you increase, you want to make sure it's working, whereas if you decrease a medication dose, you want to make sure that the patient doesn't have a flare-up of their pain. And if there's a change in the patient's pain, the location of that pain, or the severity, you want to perform another assessment. Like I mentioned before, you want to do these assessments at ongoing regular intervals. But the assessment should also be individualized to the patient. And again, if you didn't document it, it didn't happen, so make sure you document all of these assessments thoroughly. So PQRS-TU symptom analysis. Dr. McPherson, what does this all mean?
Well, this is just one of many models used to assess any complaint that a patient has. It could be, I've been coughing, my toe feels funny, I have blood in my urine, or I have some ache or pain. So no matter what you tell your healthcare provider is wrong with you, they're going to ask questions to try and characterize that complaint. So for example, with pain, you could ask what brings it on or makes it worse, and what medications have you tried, how well did they work, and did you have any side effects? They're going to ask you about the quality. Can you use your own words to describe what the pain feels like? Is it achy, stabbing, shooting, throbbing, gnawing? Things you described in the previous section. They're going to ask you, can you show me where the pain is? So where is the pain, the region, and does it move anywhere? Does it shoot down your leg, go around your back, hurt your shoulders? The severity, and I'm sure you'll talk more about various severity rating scales. You've already mentioned the 0 to 10. They're going to want to know all about the timing. Is that pain there all the time, or does it come and go? If it comes and goes, how many times per day, and how long does it last, and has that changed? And you, meaning YOU, how does the pain affect you? I think one of the most important questions we can ask is, what would you like to be able to do that you can't do now because of the pain?
And we say patients suffer in a lot of different ways, so having a high level of pain could reduce your appetite, how active you're able to be, as well as your relationships with family and friends. Let's start out with a case study. DG is a 36-year-old male who presents to his primary care physician complaining of severe abdominal pain. He describes the pain as gnawing and achy, like someone is crushing me from the inside.
That sounds awful.
It does sound awful. Based on his description of pain, what section of the PQRS-TU symptom analysis would his description fall under? So, for P, is it palliating factors or things that make the pain better? Or provocation, so these are things that would make the pain worse, as well as previous therapies. What has the patient tried? Option B for quality, C for region and radiation, or D for severity. Why don't you take a minute and write down your answer? So it looks like he was describing quality. He said this pain is gnawing and achy, like he's being crushed from the inside. So these are descriptive terms of the pain's quality. There are a lot of different types of assessments that have been validated in clinical studies, but it's important to remember that the assessment tool is only as good as the user. So just because you're using this fancy PQRS-TU symptom assessment doesn't mean that it's going to fix all of the patient's issues. You have to be thorough and make sure that you're really completing the assessment in a systematic, methodical way. Some considerations for completing the pain assessment. First, you want to determine if the patient is verbal or nonverbal. A lot of people get hung up on this, and actually one of my least favorite things is when I look in a chart and I see pain was unable to be assessed because the patient was sleeping. Just because somebody isn't able to speak to you doesn't mean that you can't assess them for pain. You also want to assess for more than one source or type of pain. And unfortunately, a lot of patients have multiple pains. So they might have chronic lower back pain as well as a sharp pain in their leg, perhaps from an injury. Again, you always want to ask open-ended questions instead of leading questions or yes and no questions that might limit the conversation. So instead of saying, "Do you have pain?" ask the patient, "Where is your pain?" or "What types of pain do you have?" It's important to build trust with patients, especially if you're coming in to look at their pain. They might be a little hesitant to really divulge all of that information to you. So you need to be patient and go through those questions one by one. And again, assess and reassess for any changes in the patient's status. And again, as pharmacists, we always emphasize the importance of documenting what it is you do. So Dr. McPherson, have you seen this scale before?
I think I have a timer 1200.
This is all over. If you look at any kind of medical record chart, you will probably see this scale. So this is a pretty easy one to follow. It has the same indicators for no pain, mild pain, moderate, and the worst pain possible on that scale from 0 to 10. This next one is a little bit more free form, so it doesn't have defined intervals, and you would just ask the patient to point on the scale in between no pain and the worst possible pain. But I find that sometimes this one is more difficult for patients to really understand. This next one just breaks up the different descriptors into more specific things, but again, you want to determine if this is really appropriate for the patient. Sometimes throwing all of these different phrases at the patient can be overwhelming. If I asked you, do you have no pain, mild pain, moderate pain, severe pain, very severe pain, or worst possible pain, it would be really difficult for you to answer that. This is another pretty famous pain scale. This is the Wong-Baker FACES scale, and this was developed for pain assessment in children. So you are matching the patient's face to the scale, or asking the patient to pick the face that most closely represents how they're feeling. Like I mentioned before, just because a patient is nonverbal does not mean that you cannot interpret their pain. So on the left-hand side, we have a number of different behaviors, such as nonverbal vocalizations. Is the patient moaning and groaning in bed? Facial expressions that I look for, especially furrowed brow. Even if a patient is sleeping, if they have a furrowed brow, this could be a good indication that they have unrelieved pain. Bracing refers to clutching onto furniture or equipment such as bed rails. Restlessness, so is the patient rocking back and forth to try to relieve their pain? Or constant hand motions. The patient might be rubbing the area of the body that hurts, or they may be making other verbal complaints such as ouch or that hurts. And this could occur when they're not moving or when they're being manipulated for procedures such as the insertion of an IV line. Pain management goals. So my goal is to have no pain ever. Dr. McPherson, what do you think about that?
I think it's good to have a dream, but that's not always feasible.
Exactly. So one of the things we always tell patients is unfortunately a score of a 0 is not realistic. And this is due to a number of different factors. We have limitations in how well some of these medications work, but also if we were to dose the medications high enough to get rid of your pain completely, that might be accompanied with unacceptable side effects. We might put you to sleep if we do that. and then you won't be able to interact with your loved ones. Like all of our other areas of palliative care, these goals for patients are specific, they should be measurable and patient-centered. So one of my favorite things is to look at the activities of daily living and the impact of pain on their quality of life. So what were you not able to do before that you can do now because we have improved your pain control? Maybe they're able to play with their grandchildren for 30 minutes a day, or take their dog for the walk that they really enjoy after dinner time. You want to establish a number of different factors to assess pain management, and typically we consider a 30% reduction to be clinically significant, but this can really be difficult if you're asking a patient to say if their pain is mild, moderate, or severe. If you're using those verbal descriptors, what does a 30% reduction really mean? So again, using functional status and what the patient is able to accomplish day to day is another surrogate marker for pain management. You also want to consider the presence of side effects. Ideally, they should be absent or minimal, and the patient's satisfaction with the pain management therapeutic regimen. So now we're getting into some of the meat of the matter. As a pharmacist, this is probably my favorite topic. At the top, we have non-medication modalities to pain management, and then medications have a lot of different options. So we have the non-opioid class, opioids, and adjuvant analgesics, which we'll discuss in the next few slides. So for non-medication pain management, Dr. Brandt, is this something that we really do for patients?
Absolutely. Especially in the world that I reside, when we look at behavioral changes and we look at some of the precipitants for that, we always look for pain. And we need to make sure that we're not just treating with a medication, but we're doing non-pharmacologic tactics as well. And again, when we're balancing the risk as well as the benefits, the side effects of some of these medications can be huge. As you alluded to, the somnolence, but also the increased fall risk with these medications, because they may be affecting our response time and our reaction. So definitely want to optimize any non-pharmacologic approach as much as possible.
Well, and fall risk could be a double whammy. If you relieve my pain and then I fall and break a leg, I'll just end up with an additional source of pain. So these non-medication management therapies should always be incorporated into a patient's treatment plan. You never want to rely on medications alone. And again, you may not be able to reduce or eliminate the pain completely, but these options can help patients improve their ability to cope and reduce their suffering. The level of response will vary between patients, so again, ask them about their individual preferences and beliefs, and if they've ever tried any of these modalities in the past. Some examples of non-medication pain management therapies include heat and ice. Those are pretty traditional methods. Relaxation and guided imagery, and actually some hospitals now have a relaxation channel on the television. So in addition to watching soap operas, you could actually watch a relaxation channel and help reduce your own pain. Meditation and mindfulness are very popular themes right now. Energy therapy, acupuncture, Reiki, as well as massage, distraction, and I think my favorite would probably be pet therapy. Starting out with non-opioids, these are agents that can be used by themselves for the management of mild pain. They can also be used in combination with opioids for moderate or more severe pain. But often the use of these agents for pain is limited due to the presence of coexisting conditions. But what does that really mean? So a common non-opioid pain medication is acetaminophen, or more popularly known as Tylenol. This agent helps with pain and can reduce fever. However, the maximum dose is about 3,000 milligrams if you're doing self-treatment with over-the-counter medications. And you want to be careful because acetaminophen is commonly found in a lot of cough and cold combination products, and you want to make sure that you aren't exceeding that maximum daily dose. The reason being, you can get severe liver damage if you take too much of this Tylenol. So if you had to take 10,000 milligrams a day of Tylenol to relieve your pain, it's not a good option. You should avoid the use of this agent in any patients who have liver disease or patients who drink alcohol, as this will increase their risk of getting liver damage. Another popular class of non-opioids are the NSAIDs, or non-steroidal anti-inflammatory drugs. The common ones we see from this class are ibuprofen, which is the active ingredient in Advil and Motrin, and naproxen, which is the agent contained in Aleve. These also help with pain, fever, and also work to reduce inflammation. They come as prescription and over-the-counter formulations, and some of them are even available as topicals. But again, these do come with some side effects, unfortunately, such as stomach bleeding, so we always encourage patients to take these doses with a small snack or a meal. Also, kidney damage and worsening heart failure. So in some of our older patients who have multiple disease states, such as chronic kidney disease, heart failure, and diabetes, these probably are not great options. And again, avoid them in any patients who have a risk for bleeding, if they drink alcohol, or have a history of kidney problems. So opioids, these are really our big gun agents. We want to avoid using the term narcotics because the phrase narcotic actually refers to anything that causes a stupor, and this has a really big negative connotation. No patient wants to know that they're being prescribed a narcotic because it makes them sound like an addict. Some of the common opioids that we use are morphine, hydrocodone, hydromorphone, fentanyl, and methadone. These opioids are used more for the moderate to severe pain that patients experience, and again, you can combine these with or without the non-opioid agents. I think a common misconception with opioids is that once you get to a certain level, you can't go up anymore. But Dr. McPherson, what do you think about that?
Well, I don't think there is, as you show on this slide, any hard line in the sand to say, yep, that's the maximum dose. I do think that once we get to someone taking morphine, maybe 60, 80, 100 milligrams a day, you have to take a second look and decide, should I add a different medication to the regimen because this doesn't seem to be getting it done. So while there is no hard line in the sand, and I think your last bullet is important too, if all three of us had pain, we probably all three would need a different amount of analgesic.
So it's not a one-size-fits-all kind of situation. And again, there is a significant variability in response between patients. So they may get relief from one opioid but not another, but this also occurs with side effects. So some patients will experience unacceptable side effects from one opioid that they won't experience with another one. So sometimes we'll have to play around a little bit and try patients on a few different opioids before we settle on the right one. So these agents are not without harm. So some of the common side effects that we talk about with the opioids are drowsiness and sedation, confusion and delirium, as well as nausea and vomiting. And this is something a lot of patients complain about. When they take opioids for the first time, especially those first few days, the nausea and vomiting can be very distressing. Itching is caused by a histamine response from the morphine and also can be very irritating for patients. So there's a star next to constipation. Dr. Brandt, why is constipation so special?
You should definitely expect constipation with opiates. And I think I remember one of my favorite faculty members who said the hand that writes the opiate prescription should be the same hand that writes the laxative, right? Because you're bound to get constipation with routine use of opiates.
Absolutely.
And would that be Dr. McPherson, Dr. Stewart?
That's right.
Yes.
Constipation is my favorite topic.
But not my favorite symptom. The other thing with constipation is that you will not develop tolerance to this. So with other side effects such as nausea and vomiting, these will typically go away after a few days of therapy. However, constipation is going to be your constant friend if you're taking opioid analgesics. It'll stay with you forever. Some of the more serious side effects are respiratory depression, but I think an important point to mention with this is that usually you'll see sedation in a patient before they stop breathing. So anytime you're talking to a patient about monitoring for side effects, keep an eye out for the sedation, as this will happen before respiratory depression. And then pupillary constriction. Opioid tolerance. So this is another area where we provide a lot of education. This refers to the natural response of the body to some medications, including opioids, but this is not the same as addiction. But what it means is that patients may need an increased dose over time to get the same benefit of analgesia. And sometimes when you get to too high of a dose, it may be beneficial to rotate to a different opioid. And Dr. McPherson is really kind of the queen of doing opioid calculations and rotating patients. So if you have questions about this, she's the girl to ask. So then the last class are our adjuvant analgesics. And these are medications that are not typically or classically used for pain, but it have been shown to be beneficial in pain management. These agents are frequently used alone or in combination with other medications, especially for treatment of neuropathic pain, and that's really a tough type of pain to treat. Unfortunately, these agents are not effective for sudden breakthrough pain that patients might experience throughout the day, and they need to be taken on a regular basis to be effective. Looking at some of the common adjuvant analgesics, like I mentioned, these are drugs that are commonly used for other conditions. So antidepressants, anticonvulsants used for epilepsy, anesthetic agents, and corticosteroids, which can be used for about 1,000 different things. Anytime you start these agents, you want to talk to your patients about the benefit for pain because you don't want to prescribe an agent like amitriptyline or Elavil, which is an antidepressant for pain, and have the patient think that you're assuming that they're depressed. So let's get to a case study. During a chart review for a resident of a long-term care facility, you notice that Mr. Klein is on many medications, including several for pain. He was prescribed oxycodone 5 milligrams by mouth every 4 hours as needed for pain as part of this pain regimen. So Dr. McPherson, what do you think this oxycodone agent is? A non-opioid, an NSAID, an opioid, or an adjuvant?
I think I'm going to have to go with opioid on that.
I have an inkling that you're correct. And it looks like you are. So oxycodone is one of the common opioid medications that you'll see prescribed in patients. Which of the following are potential side effects of opioid medications? Dr. Brandt, I think we looked at that slide together. What do you think?
I think we're going with all of the above, the nausea, vomiting, as we talked about, especially in his particular case, this is an as-needed medication. So I always say as-needed medications in long-term care are traditionally given. But if they're being given, what are some of the side effects? Indeed, all of the above in terms of sedation, constipation. So
Let's take a look. And you're right, it does include all of the above.
Now, which of those will you get tolerance to as time progresses if you continue taking the opioid? That's the big question.
So I think if I did my homework right, you would develop tolerance to the nausea, vomiting, and sedation, but you'll never develop tolerance to constipation. Is that
Righto.
right?
That is correct.
Awesome.
I'll share my cookie with you.
So some dosing considerations. How do we choose what dose to use in patients? Some of the things as pharmacists that we consider are the presence of comorbidities, and we talked about this with some of the non-opioid therapies. So chronic kidney disease for patients getting NSAIDs, or the presence of liver dysfunction would be concerning in somebody taking Tylenol. Are they taking other medications that might interact and cause negative side effects? The patient's age, and there's a common adage, especially for our elderly patients, start low and go slow. What does this really mean, Dr. Brandt?
well, because of the increased risk for having adverse events that are dose-related, you want to start at a low dose, slowly titrate up, but make sure you get to those therapeutic goals that we've been talking about.
So it's like when you get on a first date, you want to get to know each other over a longer period of time. Also, looking at patients' kidney and liver function, as these are common reasons to adjust the dose of medications. What type of adverse effects are we anticipating, and are they more common at certain doses? And typically, we anticipate that at higher doses, you will get more side effects. And also, the patient's weight can come into play, especially if they're a really tiny, frail little old lady. I always like a little bit of alliteration, so one of my favorite things for pain management is to remember the 5 A's. This refers to analgesia, or the level of pain relief, affect, and this is really how the patient presents to you. So do they have a flat, kind of unemotional affect? Also the presence of adverse effects, such as constipation or nausea and vomiting. Activities of daily living, so are they able to brush their teeth or cook meals for themselves, keep up with their bills? And lastly, we don't always like to talk about this, but aberrant behavior. So is the patient taking their medications as prescribed, or may they be diverting them to a family member or another situation that we are not so excited about? Some tips for managing pain medication. It's pretty common for patients to require multiple medications in order to control their pain. And it may also be necessary to take these at regular intervals to maintain efficacy, even if the pain is not always present 100% of the day. Patients should not wait for the pain to become very severe before they take a dose, and it's also prudent to consider using breakthrough opioids 30 minutes prior to a scheduled activity. So if you know that a patient has severe pain anytime they get out of bed, if they'd like to get up and go to dinner, consider giving them a dose of their opioid 30 minutes before mealtime. That way, when they do go to get out of bed, they'll be covered with some level of pain relief. So we always have some myths about pain management. The use of pain medications does not hasten death, but this is something that comes up pretty frequently in our hospice patients. We get asked a lot, well, if the patient is dying, do we just put on a morphine drip and turn it up? And the answer is absolutely not. We always seek to relieve patients' pain, but not to the degree that we're hurrying things up. And again, pain is not something that patients must go through or suffer through at the end of their life. And regular use of pain medications or the requirement of higher doses does not necessarily indicate addiction. And when you have treatment for conditions such as cancer, if the cancer itself is progressing, it's likely that the patient will need higher doses of pain medication to accommodate for this. Another important point is that the minimization of pain medications at end of life is not an important goal for patients. If you would like to learn more about pain assessment and pain management, please check out some of the following links. This concludes Pain Assessment and Management Part 2. We'll see you back here for Module 3 for non-pain symptom assessment and management.